Hello and welcome to webinar series. Shanti here this side, and we cross-check before boarding a flight. A live patient even deserves more cross-checks every time, every patient. Reason we chose this topic on cross-check is very mandatory, not an optional figure at all. For this discussion, now I welcome Dr. Aditya ji, who is our senior consultant and critical care intensivist from Yashoda Hospital, Malakpet unit. I welcome you, Dr. Aditya.
Thank you, Shanti ji, and welcome everyone. I'm a critical care consultant, and as we all know, our ICUs are pretty dynamic and very busy, creating a scope for various errors. Hence, it is required and it's mandatory that we cross-check everything that we do, and medication safety is one of them, and then it requires a very keen eye, rather two sets of eyes. That is what we are going to talk about. And it's a very wonderful topic to discuss. And I hope that everyone who is attending this webinar will learn something out of it. Thank you.
Yes, thank you. And we are all privileged and very honored to have you with us today. And
Thank you.
I request you to just little, increase your volume. Yes. And
Yeah.
yes, Nurses Day is around the corner. Let's hear Irene's message for the same. Yes, Irene.
I wish you all a very good afternoon. And as Madam said, as we continue, I would like to just honor all the incredible nurses that happy International Nurses Day in advance. As you know, that angels not only lives in heaven, some angels just walk around in the hospital corridors. And their dedication and diligence really save lives. So thank you so much to all.
Thank you for your very wonderful message to all the viewers. Yes. Let us see what we have in the rest of the discussion. Yes. Over to you, Dr. Aditya ji. Like, as we are looking at this article, very, recent articles which I have just taken from WHO guideline. Yes, do cross checks, reduce preventable harm and near misses in the clinical scenario, especially in the full volume ICU. Yes, over to you for your short insight.
Yes. So as we can see, the prevalence based on the latest report, um, I think you can say maybe 1 in 20 patients, they experience medication related harm. And the main focus for WHO for this year is reducing the preventable errors by 50%. And that is what we are talking about. And this is the focus for this year. Yeah.
Yes. Yes. So, yeah, now I request all the speakers, yes, over to you, Surekha, because
Yes.
see, we have speakers now, Irene and, Surekha, you all are the bedside nurse managers, and rather more than Rosaline or Dr. Aditya or from my side, we must be learning and trying to gain a lot of insight from you so that nurses across, they also learn or they correct what is not happening right. Yes. Sureka, as per you, like as you're working as a shift in charge and going to be a nurse manager in that full volume ICU, is harm avoidable? Can we prevent harm? Yes, over to you. What you understand? Yes.
Yes, good afternoon, everyone. I am Shureka, working in SCCU management. So this harm is avoidable by following the standard protocols and standards of care. So by following the hand hygiene techniques and 5 movements of hand hygiene, we can prevent these infections to the patients and high alert medications. Every single time we have to cross check with the double check with the seniors and doctors who are available in the ICU. We can prevent this harm avoiding to the patient and patient risk of fall, those who are on the when patients got admitted in the ICU, immediately we had to assess for the harm to the patient, so we can prevent these harms.
So, Dr. Aditya, for your little more insight on the same, like you are the intensivist and maybe in your past institution and in the like in general scenario, does this nurses they identify what has caused wrong to the patient? Like maybe one day they must have done wrong medication to the patient, the very next day, how do you see them? Like, do they inculcate the right practices? The correction is given. Do they come to you and ask for the corrections? Yes, over to you.
Yes, yes, definitely. Because as we all know, in our critical care environment, it's a multidisciplinary team. So many people are
Yes.
involved, and then harm is, it's bound to happen, but most of them can be prevented by proper acknowledgement. I would like to put it that
Yes,
way.
correct.
But if things go wrong or something untoward has happened, we do have a system that we report it proactively so that it doesn't happen again. And then they do come to us, and then we sometimes see what has gone wrong. It can be anything, it can be transcription error, prescription error, whatever.
Yes.
Sometimes if we don't see it, our nurses, they proactively they see, and then they come and tell us. So it's a two-way thing. And if at all something of that sort happens, we do put in advice and then a teaching point to them so that this doesn't happen again.
Yes. I think that is the say goes with like nurses are empowered enough to save the life of the patients. Yes, a very productive insight you have provided. Yes. So now we do have Rosalind. Rosalind, you would like to give your intro in short. And Rosalind is the program coordinator and educator across the 4 units, and she may have or must have mentored very, very, good amount of nurses till date, I think. So, Rosalind, when the nurses comes to you and when you talk to them, what are the common errors they see in the hospitals, like, because you are the one who you provide the corrective actions for the same as for the provided protocol which is happening in the Yashoda. Yes, Rose, over to you.
Yes, ma'am. Thank you. Like to mention some of the very common errors we see in the hospital, we have patient falls, transfer of wrong patient, medication errors, pressure ulcers, wrong report dispatch, wrong summary dispatch, wrong documentation, lab reports, transfusions. All of these are very much preventable. So we have a lot of protocols in place, but still sometimes, yes, mistakes do happen. So like Dr. Aditya has very rightly told, there is a way to report. So reporting is a very good thing that we do, and then we learn from it. So out of these, I think the most common errors that we see are related to medications, pressure ulcers, and also about patient falls. So we insist upon the assessment scales. We identify the risks in advance, and we train them on that. Also, we do a lot of follow up on this. So to shorten it, everything boils down to one point, that is the 6 patient safety goals we insist upon. So following this can actually prevent most of the errors.
So let us also understand from Irene. Irene, from this existing slide only, we would like to ask, like, what kind of medication errors maybe in your internship period, or maybe when you must be when you were taking the training during your
Yes.
nursing period, what kind of medication errors so far you have witnessed? Yes, over to you, Irene.
Yes, ma'am. Thank you. Myself, Irene, and I'm working as a nurse manager here in ICU, High Tech City branch. So I would like to just say about medication errors. So what I observed, and in general, wrong medication. Like an example, has advised amoxicillin, and by mistake, without cross-checking, someone given amlodipine. But we can prevent that by following the GLASA precautions or Tolman lettering. Cross-checking can help. Also, sometimes prescription error. As like example, doctors writing we are not unable to understand sometimes. So we have to verify and clarify as soon as possible with doctors. So
So,
also,
yes, pertaining to this discussion, do nurses approach your, guidance for the same, like whenever they wish to cross-check, not whenever. As our topic says, it is the cross-check is mandate, not an optional,
yes,
statement at all. So, do they approach you whenever they are handling these high-risk drugs? Example,
yes.
your alpha dex, your paralytic agents, your
Mhm.
dopamine, dovitamin infusions, and all. Do they approach you?
Yes, ma'am. Yes, definitely. As a senior, we always cross check with staffs. Always.
So again, same thing. We like to understand from you, and we also will check with Dr. Aditya ji. Firstly, with you, like, what are the most frequent medication errors commonly you observed in ICU? Like, as this slide also is pointing on high alert medications, which demands, double check. So what are the common medication error you get to see or you must have seen in other setup? Yes, over to you. Yes, I did.
Yes, so one more error we can say is dispensing error. Sometimes after prescribing and transcribing while dispensing, the pharmacist may forget to cross-check, or sometimes she might be busy. So we are the one we have to cross-check with it. So we can follow, we can do it. That can prevent the error. Also,
Yes.
incorrect dose, wrong route, delayed time, improper storage. Like sometimes insulin by mistake someone kept without like outside of refrigerator for a longer period of time. So
Yes.
the insulin might not work in the body. So also here failure to observe and evaluate. Sometimes we're giving hypertensive drugs and we are not following the vitals after and before giving. That might happen and that can lead to a life-threatening conditions. So
Yes.
we have to make sure to follow vitals before and after giving medication.
So, yes, very great examples you provided. Yes. Surekha, the other end, Surekha, we have also Surekha from Malakpet. Yes, Surekha, do you agree with what Irene has just, discussed?
Yes, ma'am. Absolutely. As Irene said, this is 100% correct. So we have to cross check, and we are the nurses. We are the last persons to cross check it when we receive medicines from the pharmacy. So we
Yes.
have to follow this correctly, and
Yes.
double check is mandatory, and we have to check it properly.
Yes. Yeah. Over to you, Dr. Aditya. What do you think? How should we just, conclude this slide? And what is your
Yes,
message you would like to give to
yes.
the nurses out here? Yes.
So as rightly pointed out by Irene and Surekha, that all these kinds of errors are prevalent. One thing all that I would like to point out is that sometimes in the prescription, whenever the patient is getting shifted from one location to the other, the same group of medications are being given. For example, for antihypertensives, all right?
Yes.
So calcium channel blockers, two different drugs in the same class, they may be given. It's just
Yes.
that a small recheck or probably a cross check by a two sets of two people or rather a team
Yes.
would prevent it. The other thing what I would like to point out is that while giving some medications, like it will come under medicine error, the way it's being given,
Yes.
the medication which is supposed to go as an infusion may go a little bit on a faster rate. That can be sometimes detrimental. All
Yes.
right. So again, the cross checking and then proper labeling and then probably two people overseeing the administration will definitely reduce the error.
Yes. As you rightly said, overlook and overcheck the right amount of dosages, whether delivered or not. Yes, going forward. Yes. So yes, now we have roles like as we were understanding, many of the nurses, maybe freshers, maybe interns, they may not understand what is actually harm. What is like harm and which is causing harm to the patient. Like, yes, Rose, over to you for your insight on the same. And you think this nurses, whenever call them for the training remediations and all, do they verbalize under which circumstances or challenges they undergo and they just create do a error? Yes, in general scenario. Yes, over to
Yes,
you,
ma'am.
Rose.
In literally, if I have to define what is harm, then it is direct bodily damage and emotional trauma resulting from medical care. The examples
Yes.
we displayed here are patient falls and healthcare associated infections. Now, for someone, a novice nurse, to ask something that she doesn't know, she can be a little scared of. So, we even try to emphasize on this when we are training them that yes, when in doubt, you always have to ask, get it clarified, and when you're 100% sure about administering, only you can administer. We have mentors for them who will guide them even when they are posted on the clinical side. So that is how we try to build their confidence and they gain their knowledge through their experiences.
Yes, as rightly you said, to gain the confidence, and we urge all the viewers and our internal and external nurses that do not be fretful. You must ask, have a method of open communications. Yes, yes. And yes, Sureka, what do you mean by a simple check and a cross check?
Simple
Cross
check
check,
is
like how you check and who should do the cross check. Yes.
actually cross check is done by the person, like those who are giving medicines to the patient, ma'am. Like normally will independent cross check will be done by the person, and later on the shift senior or doctor will be done by the double cross check.
So
So
one second here. You mean the cross check means two nurses with the same experience, or a junior
uh,
nurses to a senior nurse, or the nurse with the doctor.
nurse with the doctor, ma'am. Cross check will be
Yes.
done by the nurse with the doctor and between the senior and junior also. So we can check back like that.
Yes, you would like to give the example as the slide
Yes.
says, the very high
Yes.
risk drug which is unfractionated heparin. Yes.
Yes. Like as we have 25,000 units heparin and 5,000 units heparin, suppose doctor has advised 3,000 units of heparin. So some may mistakenly they have able to give the 3,000 units of heparin, like they are using the 25,000 units heparin. So the
Yes.
cross check is mandatory by the seniors, and with the two eyes we have to monitor it carefully. So it's like a mandatory.
Yes.
So we have to communicate with the doctors also whenever we are administering high risk medication.
So, as you rightly said, these are look-alike
Yes,
vials.
ma'am. These
These
are
are
like
look-alike, yes. So, it's very important that nurse, before she dilutes solvent to solute, she should read at the eye level. Same thing to be cross-checked with the other nurse or with the doctor. Yes, very rightly you pinpointed is now our the main theme of the this topic is cross-check is mandatory,
yes, ma'am.
not an optional, yes.
Yes.
So here we would like to understand firstly by the program coordinator, none other Rose. Do you think two pairs of eyes can prevent a lot of near miss errors? Because this two set of eyes may be yours and this two other set of eyes may be mine. So it is like two pairs of eyes. Yes. Over
Yes.
to you, Rose, for the first.
Definitely, a two pairs of eyes can definitely bring down a lot of near misses, ma'am. Sometimes things are not looked upon, sometimes they are overlooked. So in either cases, when there's a second person who's cross-checking, we can prevent a lot of near misses. We have certain examples. If we take a high-risk task like insulin or heparin, high-risk medications, when a second person cross-checks the dose or the units, we can prevent a lot of harm that can be done to the patient, even death at times. So this can be definitely prevented by cross-checking by the second pair of eyes. Same like chemotherapy, calculation or patient ID. If we cross-check, we can prevent fatal overdose for the patient. Blood transfusion, if the bag or the mismatch patient ID is cross-checked, then we can prevent hemolytic reactions. Pediatric decimal errors can be prevented. The rates and concentrations when given through infusion pumps, if they are cross-checked, then we can prevent harm of giving an overdose or an underdose to the patient. So yes,
Yes.
I do agree that two pairs of eyes remove that failure point or that critical point that will help us in ensuring patient safety. So
Yes.
an independent double check is non-negotiable, especially for the high alert medications. And
Yes.
whenever
Yes.
we are receiving any verbal or telephonic orders, we insist that they follow the read back mechanism and independent check. So
Yeah.
considering all this, a lot of errors can be prevented by two pairs of eyes.
Yes, as rightly you said, and very beautiful and productive insight you have provided. As over to you, Dr. Aditya ji, how do we prevent this, decimal errors? Like, yeah, maybe, sometime MCG becomes microgram and milligram, and sometimes the decimal is skipped or transcription error must have happened. Yes, over to you. What kind of little, note you would like to tell the nurses to be very careful with? Yes.
Yes, there should be emphasis on clear documentation, write it in capital letters. All right. So
Yes.
like, MCG, MG and everything, there can be the words they can mix up. So capital letters, clear spacing, and again, as described earlier, rechecking again. If at all something is written, then and there you have to confirm with whoever has written. And then emphasize that this is the need that this is the important that we need to do.
Yes.
And I think these are the ways that we can prevent. Yeah.
Yes. And do you encourage independent check? Like, yes, Surekha, you want to
No,
check
ma'am.
everything on your own, or you want to just check until the injections are very familiar and daily used medications, or you want to avoid this independent check for the high risk scenario, high risk medications administration?
Uh,
Yes.
yes, ma'am. Thank you. But I won't encourage this independent checkup. So every single
Yes.
time, whenever we are administering high-risk medication to the patient, cross-check by the other person, senior shift nurse or doctor. This is very mandatory. Like
Yes.
as we discussed about this two pair of eyes remove that failure points, it's absolutely correct. So we had to double check it.
Yes, so very rightly you said yes. So now coming to Irene, yes, Irene, let us also understand your view on what is mandatory and what is optional. Can you just throw a little insight on the same?
Yes,
Yes,
ma'am. Yes, ma'am. I feel always yes. It is always mandatory, not an optional. As seniors, we always need to cross check with the staffs, and we also monitor the same for everyone. Like, yes.
yes. Do you monitor? Yes. So optional means one just takes the decision on her own, right? By not making it mandate statement or mandate check with the doctors. Yes. So how many of your nurses, maybe how many when you were student nurse and when you started initially your working career, uh, like every time did you go to doctor to check whether doctor, how do I administer this? Lasix is now 2 ml. Now I'm supposed to give 40 no mg. So whether I should have the 4 ml or 2 ml vial, because many vials are look alike and many drugs are sound alike in nature. Yes, over to you.
Yes. During my intensive time or as a fresher, I had so much confusion, and I always remembered in my mind that if I have little also, then I'll go for asking, I'll go for help. Like I always ask my seniors, thanks to them, they always help me. I always go to not only doctors, I asked everyone if I have like little doubt also. Like here, patient safety is our top priority. So I always do used to do that. Now also, if I have any doubt, I go to ask and I just get it clear before giving to medicine.
Yes, very rightly said. Learning is a lifelong process. With the 3 to 5 years of experience at bedside does not, define our privileges and competency, because we have trillions and millions of nursing diagnoses at the same time, complex, patient scenario. As we see now, patients are airlifted in Yashoda hospitals and they go for, lung transplant, heart and liver transplant as well. ECMOs are done bedside. Yes. So,
Yes.
yeah.
Yes.
So over to you. Like now, we would like to understand. This is from Dr. Aditya. Like potassium chloride is a very, very, very high risk medication, and I think by when the prescription is done. During my nursing days, I used to always get little fretful because how should I give, whether peripheral lines will be okay, whether sometimes we see nurses connecting this, I said with the central venous line. Yes, and identification of the potassium chloride, like a 10 ml is equal to 20 milliequivalent, also is very, very difficult for the nurses sometimes. So, what is near miss like? Yes, over to you, Dr. Aditya. Like,
Yes. So as rightly pointed out, near miss is that it has a potential to cause harm, but it not reach the patient, right? So it
yes,
just nearly something, a catastrophe has happened. So if you're
yes,
taking the example of potassium chloride, okay, and then sometimes there may be, you take 10 ml or 20 ml or 30 ml, but the concentration would be much more.
yes,
And they put it, sometimes we infuse it over 50 in 50 ml, sometimes we infuse it in a 500 ml bottle. Okay. So if there is any difference in infusion rates and everything, then again, if it doesn't reach the patient and timely if we intervene, then that is called as a near miss. As we all know, potassium chloride has a propensity to cause arrhythmias and it can be fatal also. But when there's a potential to cause harm, when it was identified and then it doesn't reach the patient, then that is called as a near miss.
yes, yes. And yes, Rose, you think near miss to be also reported, because in Indian system scenario, near misses are considered as a free lesson. Like I think everybody should learn out of this. But if at all in overseas where I used to work in Australia, so I see near misses are also captured as a not full blown error, but it is one error type, thing. What is your update on the same, Rose?
Yes, ma'am. Definitely that would help. Reporting a near miss would definitely be a lesson for everyone, so that a similar error would never happen again. We will sensitize the nurses and they can follow the same. A lot to
Yes.
learn from, thereby preventing an error as such.
Yes.
That would be
So
great
yes.
to report.
So we have come to the end of the slide now. We have just quoted a few of the training which happens in our industry. And I thank to the management, especially Dr. Pawan and Dr. Lingya Garu, that they always emphasizes on the and strengthens the training process, along with the chief intensivist and Dr. Aditya, Dr. Kaladhar also is, they look very closely for the same. But of the job training techniques, does it helps? Because not every time we provide the on-job training for the nurses, because nurses are busy, they may be little distracted, or maybe you're observing them, example. So of the job training techniques, does it help? Like simulation, clinical certifications, nowadays it is happening. Nurses are, opting out IDCC and stroke protocol, all that. Yes, over to you.
Yeah, ma'am. Apart from on-job trainings we do when we identify a mistake or we see something that is being happening and we give them. Apart from this, on a regular basis, if they give them some certificate programs or some modules specifically, and participation in conferences or regular assessment does inculcate that habit of seriousness in them. And we will definitely come up with more competent nurses who will not compromise on patient safety. So yes,
Yes.
training would definitely help them.
Yes.
I
And
would
I think Dr. Aditya, you will also,
Yes. So yes, it's a very
provide
beautiful
your.
discussion. And this slide, I would like to offer my insights.
Yes.
Simulation, yes, it helps because it is a safe and I mean it's a safe methodology to relive whatever has happened,
Yes.
patient-related event, and then we can learn it in a psychologically safe environment. And certifications like IDCC and stroke and everything, I personally, I would like to say that we have enrolled our nursing faculty, I mean nursing personnel in IDCCN, and 8 of them, they have passed out with flying colors. And this is one of, I mean, I could see the change in their approach of patient care. I saw
Yes.
them while they got enrolled in the training, and then I have seen them after they have passed, and the level of competency that they have shown, the increase in the competency, it's phenomenal. They have the capacity to analyze and act, faster than the, the other colleagues. So definitely, I would like to encourage all our nursing personnel to look up to these certification courses. And conferences, yes, discussions like these will provide a platform for everyone to learn something new and then
Yes.
practice something better while we are with our patients.
Yes, so that is the reason we, request all the nurses never stop yourself learning, right? Yes, and as you rightly said, these competency will, uh, will definitely prevent a lot of the errors bedside which happens. Yes. Now we also have Irene, and Irene, we like to just hear this conclusion part from your end, and then we end the session. Yes, Irene, over to you.
Yes, thank you, ma'am. So I would like to say that nurses are the last line of defense in patient safety. Like an example, after prescribing, transcribing, and dispensing, medications is coming to us. And we are the last person who are taking care of the patient at the bedside. So if we cannot prevent medication errors, then we have failed in our responsibility toward our patient.
Yes.
So that is why we must strictly follow our IPSG goals, maintain proper cross-checkings practices. Sometimes just one extra check and one more set of eye can prevent serious harm.
Yes.
So always, I would like to say all the nurses, remember 2 sets of eye can save the patient, protect the organization, and protect us as the healthcare professionals. Thank you.
Yeah, I think this topic it was very interesting, and just because it is time bound, and we'll have to just end this session. And otherwise, I thoroughly enjoyed by talking to Dr. Aditya and rest of the speakers. And I thank Rose, I thank Dr. Aditya, thank to Irene, and I thank you to Surika also. I think yes, as you rightly said, nurses are the last defense who can always protect the life of the patient. Yes. So happy Nurses Day once again, and I thank everybody, and we end the session. Yes, Dr. Aditya, thank you.
Thank you so much.
Thank you.
Thank you so much.